Hi, this is Erica Mello, and this is podcast number 26, Exercise Progression in Low Back Pain. And in this podcast, Susan and I discuss a patient of mine who really wanted to get really specific on exercise progression. And I know in past podcasts we talk about one specific patient of ours starting you through the initial evaluation and how we came up with the diagnosis and progressing through treatment, etc. But we wanted to talk about progressing anybody through a really solid, specific exercise prescription. And prescription is the key word because one size does not fit all here. And it's really important to understand that even if two people have low back pain, that does not necessarily mean they're going to get the same exercises. And I think that is the beauty of our profession because we can really diagnose a movement pattern so well and tailor a really nice progressive exercise program for them. So we hope you enjoy it. And once again, thank you so much for listening. Hey everybody, this is Erica Mello and Susan Clinton on for another really interesting podcast. How are you, Susan?
I'm well. How are you?
I'm good.
Good.
Good. A little bit of froggy in my throat today, but I'm good. We're recording this around the summer solstice, and I think that, we've had a lot of fog in New York, and I think that always makes my throat scratchy. So we will give it a go. You want to just get right into it?
Sure. What do you have?
It's funny, I was looking over all the podcasts, and I think we've talked about exercise progression, but we really talked mostly about assessment and trying to find the cause and the driver and things like that. And I recently just had a patient who, she really wanted exercises, and that always leaves me a little bit, well, you got to do the right thing, because if you do the wrong thing, it'll make you worse. And so what I did was, I decided that I will talk about some exercise progression and how we progress people. And since we haven't really done a podcast on that, okay?
Sounds wonderful. Let's
go. So
Mm-hmm.
This person was 68 years old and a history of bilateral low back pain for many, many years, on and off physical therapy. She basically, this is her belief. And I always sort of tune into the beliefs because these people never do whatever caused their problem, they really refrain from doing it. So she felt that her back pain started when she did a lot of squats with a lot of weight many years ago. And her history, she's a former dancer, not ballet or contemporary, but a Las Vegas show dancer, wearing a lot of high heels, doing a lot of movements, never once got injured at all. If you can imagine doing when she was doing her thing in Vegas. So very sort of in shape, obviously not overweight, somewhat hypermobile as to be expected. So her main thing with me is she didn't have any pain at the time I saw her, and I actually saw her recently. She had been seeing a chiropractor on and off and some physical therapy, and whenever anybody gave her any back exercises or any glute exercises, it made her worse. And people only gave her one or two exercises. And I was like, okay, well, I don't really mind that. But if someone comes into your clinic and they're looking for a ton of exercises and that's what they want to do, I don't really think you need to give them a ton, but you need to give them more than one or two. I don't know what you think about that, Susan, but that's what she was coming in to see me with.
Mm-hmm.
So her main issue is the bilateral low back pain. Picking up luggage was obviously a big thing that would set it off. She is a very good cook, so she would stand for long periods, and she also felt that bothered her back pain. What made it feel better over the years was the heating pad, the hot shower, that kind of thing. So she also was told by former healthcare practitioners never to twist. And I was like, twist? She was a dancer. Of course she has to twist. How is she going to stand at the kitchen and turn and so
Right.
These are these cognitive barriers, right?
She's locked in cardinal plane movements.
Totally.
And
And
probably more sagittal than anything.
yep. So she couldn't, so it was basically lifting, standing, twisting. That was her main issue. She's had the couple trigger point injections and epidurals over the years. Really didn't really help. The last person she saw gave her a lot of glute exercises, prone, hip extension, things like that, which really made her worse. So she stopped doing it. She had an MRI a couple of years ago. Nothing really crazy, to be honest. Just, the usual degenerative
Mm-hmm.
stuff. And that was really her subjective stuff. And she's going to Italy for the summer, and I have like 3 weeks. So you love when people come in. You've got 3 weeks to get me pain free, or 3 weeks to get me compliant with exercise. And I'm like, okay.
Yep. Last minute.
I know humans were, creatures of habit, right?
Right.
So basically she was one of the exercises, and I thought this was a good person to talk to. I assessed her, obviously. Her back pain was really no radiculopathy, no weakness, no numbness, no tingling. It was just the, bilateral low back pain that flared up with the aggravating factors that I mentioned earlier. So, I took a look at her in standing because I knew that with the work that I had done with Diana LJ, that it's important that you need to give them the appropriate exercise for the movement that they want, that's meaningful for them. So I took a look at her in standing. She was shifted to the right, her thorax to the right, her head was centered. She had a lot of these sort of little twists. And I mean, you expect it. She's a dancer. She's fairly pain-free right now, but she's afraid to go back and do a squat with a kettlebell. She's afraid to do a twisting maneuver. She's afraid to lift. So I said, okay, I'm going to look at a squat. I'm going to see how she bends over, and I'm going to see how she twists, because she's in a safe environment. There's nothing for her to be afraid of. So just a quick look at the standing posture, just to revisit that for a quick sec. She had a lot of bias, shifted onto her right leg and rotation off to her left. And no reason. I looked at her past medical history. She really, no major injuries. This was her thing. Okay. And she said she's extremely tight hip flexors. You have to love it when people who are really flexible say they have very tight hip flexors.
Right. It's like, that's kind of like the mantra for the performing artist. My hip flexors are so tight.
Right. And no medication, just some hormone replacement, things like that. Nothing really crazy. Sleeps on her back. So the first thing I did was I looked at her squat. I'm going to go through this quickly because I want to get into the exercise. That's the rest of the podcast. I said, let's just watch you squat. And I literally stood back, and she halfway down to the squat, she was hiking the right hip up and turning her whole body to the left.
Wow.
Common. I see this a lot. And I said, okay. So then I put my hands on her, and I looked at her feet. I generally just took a whole body approach. And then I put my hands, she's very compressed thorax, as we all do. I mean, it's always human. It's very common. So I had her squat. I closed my eyes because sometimes, I don't know if you do this, but sometimes my vision plays tricks on me.
Yep.
So
you see what you think you want to see and not what's really happening in front of you.
I know. And I find that when I'm standing behind the person, I have issues in my own body. Like, I'm shifted, I'm turned, and I don't want to bias that when I'm looking at them, because it has in the past. So I just closed my eyes, started putting my hand on her thorax. She squatted, nothing happened, nothing. It was straight, still compressed, no worse, no better, nothing. Put my hands on the top of the iliac crest. Halfway down, I felt this pull. And so I'm like, okay, my vision wasn't playing tricks on me. So put up my hands on her head, same thing. She squatted, a little bit of a shift in the head, but nothing crazy. When I see someone do a movement pattern, I'm looking for something, and I don't like to say the word fails, but something that is not optimal immediately.
Right.
And this was the first thing that went. So what I ended up doing, go through this quickly, is I ended up just trying to prevent the rotation and the hip hiking. So I ended up doing, getting her back in her center of mass off the right leg with my hands manually, just to try to take the twist out of her pelvis. And I just looked at her. I didn't even have her, and it wasn't that difficult to correct. I just had my hands on her, and I watched her head. I watched her throat, looked at her feet. Nothing was worse. She was still pretty okay. Then I had her squat, and she's like, oh, that feels pretty good. And all I did was just take away her compensation for whatever that is, right? And she had no pain. So what I ended up doing was I applied, this is the work that I've learned with Diane at LJ. I applied some compressions, which would
Mm-hmm.
mimic anterior and posterior, chain. So I applied oblique compressions to the front and the back. I applied anterior compression bilaterally and posterior compression bilaterally. The posterior compression bilaterally made her way worse. And I
Okay.
said to myself, of course it made you worse. Anything to do with working your glutes, your back, it made you worse.
Mm-hmm.
This validates that.
Mm-hmm.
So then I applied anterior compression just to mimic anterior chain support. And she went all the way to the floor. She's like, oh, that feels pretty good. Then I applied some various oblique compressions.
Mm-hmm.
And one of the oblique compressions, I don't remember which one. I think it was right posterior and left anterior. Anyway, that made her worse. So it was really when I supported the front of the pelvis low down, like not at the lumbar spine, like right around her ASISs.
Mm-hmm.
And she's like, that really feels comfortable to me. And I said, well, the exercises that you've been doing were the wrong ones, basically. So, and she asked me what I was doing. I said, I'm really trying to balance the forces across the pelvis. It's not like you have a muscle imbalance. We're really trying to figure out what the best combination of muscle activation is for when you do a squat. I don't know what you think about that if someone asked you that, but that's what I said to her.
Yeah, I just tell them that, usually over time when you have a pain event, that our brain tries to figure out a pattern of movement, and sometimes things get switched on harder and other things get switched off. Yeah. And so we kind of get into a little bit of a discoordination, during movement, that if we can get that coordination back, will likely give you a better ease and more effective movement pattern. So that's usually kind of, what I say. Mm-hmm. Same kind of thing, probably too many words. But I love the fact that just kind of doing some compressions, just like as a muscle would pull onto the area, that it really validated what she said too. So that's kind of a buy-in there. That's important. It's like, yep, I can see why this would bother you when you were squatting. And this is why, every time you do that particular exercise, it doesn't feel good.
Right. Mm-hmm. She was like, okay, now I understand why that made me worse. And just before, I'm just looking at my notes. In the assessment, I did assess, passive accessory vertebral. I did all that. Hypermobile, nothing was there. It was just a normal lumbar spine, a little bit of a lordosis, as you would to be expected with a show dancer and things like that. So I decided, I spent a lot of time with her and I didn't even get her on the table yet. So I ended up lying. I said, lie on your back. I just checked her hamstring length just because she'd complained about some tightness there. It was probably tight for her. It was way not past 90, but tight for her. So I said, since you're here, let me just check an active straight leg raise. Wasn't one of her complaints, but I know there's been some words and research about how this test has been sort of validated or not validated for pelvic girdle pain, and I think we talked about this in another podcast. Mm-hmm. So I had her do it. She's like, well, they feel pretty equal, but they're both hard to do. I said, okay. This took literally a minute. I said, so I applied the same pattern of compression, mm-hmm. and the anterior compression, her leg flew up past 90, which was interesting, and same thing on both sides. So she's like, oh, that's really interesting. I said, okay, had her turn over on her tummy. I said, let me do prone hip extension, because that's what really bothered her, the exercise that bothered her. Same thing happened. Mm-hmm. Compressions, the same thing. It was really hard to lift. So I ended up doing some anterior compression, made it a bit better. So it was not the exercise for her. Mm-hmm. So then and there, we decided I needed to give her something to do, or something to, like a barometer. Okay. So she had issues with standing. She had issues with lifting. I said, you need to get what we call like a barometer or a self-check exercise or a checker. If you stand for 5 hours and you're not in pain, you could be in pain the next day or whenever, but you need to do something that's sensitive to your driver, that's sensitive to your issue. And after my assessment, and I'm really shortening it, as I believed her pelvis was her primary issue. Mm-hmm. Nothing internally, external forces. Mm-hmm. So in my experience, the two things that I give patients as we call self-checks for pelvises are squatting or standing on one leg, which is a good, like I had her stand on one leg actually, and she had no problem with that, and doing an active straight leg raise. And I felt that doing an active straight leg raise wasn't so meaningful for her, and it wasn't very um, practical. So I said, I need you to do something that's sensitive to the cause of the problem. Like, for example, how I learned this is that if your thorax was your main cause, and if you went and did an entire boot camp to check the status, you would do seated rotation. If it was good before you did the boot camp and it's not so good now, then something in that boot camp caused that to become non-optimal. Does that make sense?
Yeah, it does. I think what I'm hearing is that you're looking for exercises that are meaningful to them, or a movement pattern that's meaningful to them that has actually been problematic, and they can use that particular movement to say, am I overdoing it or not?
Correct. So for a foot problem, I would do heel raises. For neck, I would do rotation. For the hip, lunge maybe, but I believed it was the pelvis. So what we decided was, after she's done something that would have aggravated her, she would do a squat or a one-legged stance, and they needed her to feel the difference between a good squat and a not so good squat, and that doesn't mean it's painful. So we went through her doing her normal movement pattern and squat, and then with me compressing and doing, so I gave her some transverse abdominis cues, just because that were to mimic the anterior compression that I gave her, and she got it. So when she did a little bit of a lower abdominal cue, really like 20%, she said, oh, the squat's much better. I said, that is your check. After you've been standing, if you have to lift a heavy bag, that's what you do. And you need to tell me when that's not good. So if you stand for 5 hours and you do a check without your cueing, or without the transverse cue, and you do it and it's not great, we know that activity really made that worse, whether you're in pain or not. But we need to get you to do exercises in that realm. I hope I'm making sense. So when I've learned all of this, so I basically left her with, you're going to do a standing on one leg as a self-check and a squat as a self-check. No weight, nothing. These are just barometer type exercises.
When did you have her do those? Like, if for instance, with the 5 hours standing, when would you suggest that they do those tests? Do you have them do it at the end of 5 hours, or do you have them do it
I said
after an hour, after 2 hours?
Yeah, I said after 30 minutes to an hour.
Okay. All right. Yeah. I think that's important, because that's one of the things I would do. And I knew that you probably did that. I just wanted to make that clear to everyone out there, that we wouldn't just have people go and stand for 5 hours. But if they find that they're doing activities that maybe they weren't so mindful about before, or they're going into an activity worried that they're going to have problems, that this actually gives them a way to kind of use movement as a way to say, I'm okay.
Yeah.
Or I need to change something, which I love, because it fits right into the brain stuff.
Yep.
And, here's somebody who has a belief that if she does this, it's going to be a problem for her. And so you're using that to actually convince her that she can move with a different strategy. She could actually do it. So yeah, maybe with your old strategy, it bothered you, but if you change it, then it's going to change. And the other thing I love about this is it's kind of from Eric Franklin's work. It's consumer comparison.
Yes.
And this is what's so important, is how do you feel right now? Now, do this, do this, do this, do this. Now, recheck. How does it feel? Does it feel different? And it gets the brain to pay attention to those differences rather than I have pain or I don't.
Exactly.
And I love it. I love it.
It focuses them on the movement. So there are so many times when people come in and they're like, oh, I was great for 2 days, and then one day I was horrible and I didn't, and they don't have anything. I'm like, well, what did you do? Well, I did this, this, and this. So we don't know what that activity was unless we do these types of checks. And I think this for me has been a game changer, I have to say, because people who are very active, they're just going to do a bunch of things and you don't know what made them worse. And until you identify that trigger, you're just going to be spinning your wheels. So I focused her on the movement, and she was afraid to do a squat. Now she's like, oh, I can do this. I'm like, no, wait, just just do this now. And I knew I just had a few weeks. I have a few weeks with her. So that's what I left her. And I also told her, I don't know what you think about this. She wanted to, I was always taught that exercises in supine for acute, she's not acute, but for an acute pelvic or persistent pelvic problem, was not the best way to start. What do you think about that? Start them in sideline.
Yeah. Well, first of all, one of the problems with starting people in supine on their pelvis is that there's a tendency for, things to settle. Mm-hmm. So it becomes like a turtle trying to get off its back. The tissue kind of settles into the surface area that it's on, and so you put them on their back and everything kind of settles in. And if they've got sensitization,
yep,
through the pelvis, then it makes it, that can be, kind of painful moving and changing positions out of it. Mm-hmm. The other thing is that, again, I think that when you lay people down and when you just lay them on their back, there's a tendency for a lot of the postural control muscles to just switch off.
Yep.
That's Neuro 101. When you have a patient that you're seeing in the hospital that's had some sort of central nervous system event, we don't do range of motion laying on their back. We just don't do that. I mean, we know better. Let's do better. What do? You get them up. You see what turns on.
Yep.
So, because oftentimes you don't have any idea what this person's going to be like until you get them up against gravity.
Yep.
And I think for when we have people with back pain and hip pain and neck pain and, and all of this supine stuff, to me, I want to maybe put them on their back so I can teach them how to move off their back. But I'm not going to spend a lot of time just laying on their back. I'd rather them be in some other positions that might be more optimal for muscles to switch on.
Correct. Yeah. So I basically told her, because she was doing some exercises in supine, I was like, well, probably not the best. If I'm correct and that the pelvis is your driver, is the source, then supine exercises are probably not going to be the best for you, as are prone hip extension, because that's really kicking in a lot of your lumbar spine and glutes. And I just want to go back to the compression pattern that I gave. I gave her anterior compression. Mm-hmm. That also can mean posterior decompression, like release and elongation. Yes, she had an overactive superficial multifidus, overactive erectors, absolutely. But my first inclination, given the time frame that I had, was not to get her on her back and release those muscles. I don't think that would have been appropriate at this time, so I did not do that. And I do a lot of manual work, but I did not start that with her.
Right. Plus, she has been doing stuff on her back and it hasn't helped.
Yeah, exactly.
So it's kind of like, let's move to do something different.
Mm-hmm. So she's like, well, can I do sideline clamshells? I'm like, absolutely, no problem. Get yourself in sideline. As a matter of fact, speaking of Eric Franklin, I think I have his book, the dance imagery book. Was that here? It's fabulous. So I'm giving her, generally lying on her side, both sides, and having her just do a little transverse Q, just doing small range clams, not one of my favorite. I mean, I give them, but I give people them really early and then I move on because I don't like people getting on the table a lot. But she wanted to do those. I'm like, totally fine, not a problem. You can do them. That's fine. Mm-hmm. I did check her twist for people who are thinking. I did check her in a standing body twist. She had no problem. And I checked her in sitting just to check the seated thoracic rotation. No problem. So I think a lot of her beliefs were just unfounded. Mm-hmm. I mean, how can you tell someone not to twist, right? Mm-hmm. I mean, okay. Yeah, I'm sorry. Go ahead, Susan.
That's all right. There's people out there that do that.
So irritates me.
Yeah.
So she went home with, the squat and the one-legged standing and just as barometers and checks. And I basically could have said to her, I could tape you, I could belt you, but you have 3 weeks. You don't need it. You're not in pain. Let's get to the exercise. So this is really what I wanted to talk about. So I tend to move a lot very quickly with patients into rotation. Mm-hmm. And because of the 3D nature of our lives. And with some patients, especially people who have issues with their thorax, I have learned the hard way that doesn't work. So for whatever reason, they've either have pain or or it feels weird. So with some of the people who have issues with the thorax, I will go rotation, but it won't be for like a week or two. So, and then I'll just sort of push that. So since I felt her issue was the pelvis, I don't know about you, but since she wanted a lot of exercises, I believe in giving people open chain, closed chain, upper and lower extremity. She had no problem with her upper extremity.
Mm-hmm.
But if she's standing and reaching, could that affect her pelvis? Absolutely.
Mm-hmm.
So squats and lunges and one-legged standing, that's really the waist down.
Mm-hmm.
So I really wanted to give her things with her arms to challenge her pelvic control when she was using her arms. I don't know what your thoughts are on that.
Well, if the pelvis is kind of the cornerstone of the body, then you have to, it's balancing forces from above as well as below.
Right.
So I think, plus it's also a great way to get other muscles to play and to, just enrich her system.
Yep.
She needs to balance the forces from above as well as below. And if you're working on the anterior chain, if that's the one that tends to be not as wonderful as the backside,
yep.
or the backside's overworking a little too much, by doing some different things like that, you can actually, again, you're just trying to enhance the system and get it recoordinated. And I think I've always said that with back pain, you have to load up from up above as well as down below. So some of the ways we can do that is by picking things up and moving them around,
right.
up above, as well as, picking them up off the floor. But then what happens when you have to put them up on a shelf?
Right. Exactly. Exactly. Perfect. Exactly. So I ended up giving her a basic squat with either, because she doesn't have really access to a gym. So I had her like take a TheraBand or some light weights and just do the squat, do like a bow and arrow and that's rotation. And I did that quickly because I wanted to take away the fact that she couldn't rotate, and I knew she wasn't in pain, so that's why I really could have pushed this a little early on in a squat, just doing sort of bow and arrow, like literally just shooting like a bow and arrow back and forth, right hand out, left hand out, sort of getting the rotation with volume. So I'm not the kind of person who does, just do 2 sets of 15 with these types of patients. I know that there's been a lot of research on motor control and the volume of exercise. So I was like, you need to do 40 reps, 50 reps of this, So I don't know what your thoughts are on that. That's important for me.
Volume and changing it up. So I like the way that you weren't just having her squat 40 times.
No.
You were actually asking for movement variation in the squat. And it, in many ways, it's like, kind of what Corey Blinkenstaff talks about, exploring the edge, or his words. And I like that because that's exactly it. You're having her squat, you're giving her a new way to squat. Our brain has some choices, so she's not just squatting one way. She's got several directions to squat from. And then you're giving her some movement from above, during the squat. So, and that's good because sometimes we squat down while we're reaching up.
Yep.
It just happens, normal everyday life. You get in a squat position and you remember, oh, I forgot that up there, and you grab it, to bring it down. Like, I don't know, maybe you're getting down to the floor to do something and you left something up on the dresser. So all of those are wonderful.
Yeah.
But it's meaningful movement, but it needs to be varied. The biggest thing with motor control too is it's got to be varied. Once you get it, you got to vary it as much as possible to bring it into more of a skill level activity rather than a single isolated control type movement.
Correct. And I also gave her squats, and I'm jumping along. This is what I would be giving her. Squats, what we call with a bilateral arm lift, like a foam block, squats and do this. And she's using her little bit of a TAQ. I did assess her transverse abdominis in supine. It wasn't bad. I mean, this is a low. And so I basically explained to her that you need to turn these muscles on and in functional movement patterns. And she got that. And I said, you just really need to build volume and train different movement patterns because you have not been doing that. And she's pretty fit. I don't think this is going to take that long. So I started her with the squat with the bilateral arm lift, the squat with the bow and arrow. And I'll tell you what I would continue to do because this is what I'm going to do. I just started seeing her. So I would also add, like, I don't know what your thoughts are. like lunges with some rotation, uh, forward, because she explained to me that backwards lunges didn't work for her. I said, of course they didn't.
Mm-hmm.
Backwards lunges are going to kick a lot of that posterior chain in, and that really made her worse. So I
Mm-hmm.
started her, and this is what I'm going to do, is just giving her a little forward lunge with a little bit of rotation, bearing in mind she's going to be in Italy for the next month, walking all over cobblestone streets, going up and down stairs in the Roman Forum.
Mm-hmm.
So I started doing, that's what I think I'm going to do. That'll be more of that closed kinetic chain, lower extremity, but
Mm-hmm.
adding that upper extremity sort of rotation as well. So I like to do, I'll just mention the categories, the open kinetic chain, upper and lower, and the closed kinetic chain, upper and lower. I like to combine all of those at some point, and then depending on where their issue is, I'll kind of finesse it a bit. Like with people who have thoracic issues, they can't really push too well, so, but I believe that she's a pelvic driver, a pelvic source. So I wanted to really just challenge her squatting and her lunge in her lower extremities, so she can contract her, just sort of support her pelvis in the best way that she can.
Mm-hmm.
And I'm reluctant to get her on the table at this point to do anything, because it's just so not practical for what she's going to be doing.
Right.
So then I decided, so this is what I'm going to do after. I'm really progressing like weeks ahead, but this is my thought process, because I'm assuming, so when she does the squats with the bow and arrow, and when she does the squats with the bilateral arm left, she would check standing on one leg to see if that was better or worse. Okay. And if she was worse after 40 reps of a squat with a bow and arrow, then that exercise was too hard for her. Right. So
Mm-hmm.
that's when I would sort of tone it down. That's where those checks come in really handy. If you're giving them a new exercise and her standing on one leg was worse, then I'm like, oh, well, then something is not right with that exercise. So I would probably tone it down and not do the rotational control. So that's where I like doing those checks. So we decided, so the next visit, I'm going to decide basically that her one-legged standing is going to be her check, because she's going to be doing a lot of squats and things. That's not going to be a really good check for her at this point going forward. And, I'm speaking futuristically now. So that's what I'm going to have her do, her one-legged stance as a check after she does these exercises. Mm-hmm. And then what I want to start doing is, I don't know what your thoughts are on this, progressing with, my question is, going forward, this is all exercise, when do you start to add weight versus when do you start to change the movement pattern? Like, if you're going to do a sagittal plane squat with a bow and arrow or a bilateral arm lift with a foam block, and her main issue is lifting, do we add resistance to that movement pattern first and then start to challenge her lateral and rotational control of the lower extremity?
There's not a real answer for that. I think most of the thing is get them to move and then load it, so
Right.
I think it's probably okay. If she's got that sagittal plane motion, go ahead and load it.
Right.
I don't think it's going to interfere with anything that you're going to progress. I don't think you need to have to add lateral and rotational stuff right away. You already are with the bow and arrow.
Yep.
So you're kind of innately doing that anyway. So you're just going to load her up a little bit with it. There really isn't this is the best. You just have to, some patients are super sensitive and can't load, so you find a variety of movement patterns that they can do. They're actually loading, but they're unable to have external loads. They're trying to learn to handle their own load. So, to me, as soon as people's sensitivity starts to change, then you can, I say that's when you can go ahead and start loading. And that, sometimes adding a load helps the sensitivity to change. Again, it's one of these fluid things that I think you just kind of, and I like the idea that you're just kind of doing some checks to say, how does she look after this?
Right.
So in your exercise progression, considering that she's going to be walking all over Italy, and you were talking about the cobblestone streets and the different kinds of levels and things like that, are you going to be doing any kind of step ups? Because I like that. I'm just thinking about that because of the one-legged stance and, being able to step up and down and do things like that. Where were you going to put that in?
I was actually going to progress her to do actually a step up and
Mm-hmm.
doing some squats on a Bosu ball
Yeah.
just
Yeah.
for the balance issues,
Balance and the variability. Yeah.
Yep.
Perfect.
And that would be the lower extremity. And she could, hold a ball in her. She could hold a 10-pound medicine ball in her hand.
Yeah.
That's
Yeah.
the
Yeah.
load. And I would agree with you. I
She can
think
put a
that's
backpack on.
totally.
Like she seemed to be doing there.
Although I'm not sure if she's the kind of person who wears backpacks.
Oh, I was just thinking of, me, I'm thinking of a European traveler with a backpack on, because everybody runs around with backpacks when they're traveling in Europe.
I know. Who knows? She probably will. But it's just funny. So yes, I would do that. And I think that because of the load, I absolutely would load her just to validate that. I agree with you. And that's what I was planning on doing. And I think that I become, as I've really gotten into these whole exercise progressions, because they really helped me with these checks, I believe that we don't load our patients enough. And I know that sounds crazy.
Not soon enough and not nearly enough. Exactly.
Yeah, I really don't. And I think that when people want to exercise, and I always say, physical therapists, we're experts in movement. We don't just exercise you. We assess you. And that's my whole soapbox thing, but we do exercise people appropriately.
Mm-hmm.
And that is why I did not give her backwards lunges. I didn't give her prone hip extension. I didn't give her glute max. Not right now. That would flare her up and she'd be out the door. That's what she had in the past, and that's what didn't work. And based on my evaluation, that was making her worse in the squat, in any activity. So I just, I texted the trainer. I said, no, nothing in that plane or realm. No, nothing right now, because I need to get her to get more confidence in doing a step up, in doing a squat. So I would do a squat on a Bosu ball. I would do step ups. I mean, I climbed those stairs in the Roman Forum years ago. Oh my God, they are like 5 steps in one on a New York City subway step. You're like hiking up those things. And I absolutely think she needs to do that. And, but I would add upper extremity. Absolutely. I would not just isolate that. I would have her hold weight. I mean, you're sweating. She's probably got a asymmetrical, she's probably got a bag on, she's got a water bottle in the other hand.
Exactly. Exactly. We're not just having our arms, kind of clasped in front of our body like a kettlebell or a goblet squat or goblet step up. You got to actually get the arms moving too with it a little bit, so that you can get some ventilation with the increased exertion, because going up and down the steps, the reason we move our arms up and down is it pulls the pectoralis muscle on our chest wall and helps add ventilation, which is really important and something we don't look at. That's for another whole podcast. But getting into ventilation and how you can actually help that improve. But I love it. The only other thing that I would say is there's so many different ways to cue TA. We obviously aren't going to isolate TA. That's but just thinking about cueing or getting those deeper muscles to come on. There are ways that you can cue TA. My favorite way is once they kind of get it, I actually bring it on with breath, with an exhale.
Oh, interesting.
I can just remind them that bring your breath on as you're you're moving, to help them so that they're not having to think about too many things. They can just think about, keep breathing a little bit. So but we can do a whole podcast on that. That would be fun.
Very cool. Oh, that's awesome. That would be awesome. So just for the
list, great. I love the self-check exercise.
That's been really helpful for me. And just for the listeners, I would probably, because I want more anterior chain, I would have her squat with a weight holding in her hand in front, so that would turn that on. With that feed forward mechanism. I would have her, we have a large track where I work, and I would have her literally for the walking. I mean, she didn't have many problems walking, but I would literally have a sports cord wrapped around her, have her pull against my resistance, so she would have to cue everything, any anterior muscle that she needs, so she doesn't go backwards. I've done that quite a bit with people, because we have the track, and I can have them really like pull me down the track and focus on that. So I would do that. Would I have her do backwards walking? Probably not. Things like that. So that's where I would progress her. I would also add postural perturbations, just because either standing on an unstable surface or just standing on a stable surface, closing her eyes, pushing and pulling and forward and side, and just so she trains that feed forward mechanism. And then I would probably have her, does she need to do plyometrics? I've got 3 weeks. If I get to it, I get to it. I think that would be a logical progression. You want to do more spring stuff, plyometrics, lateral control, I would have her do lateral lunges, things like that. Absolutely, I would do that. But I think with this particular patient, combining upper and lower extremity movement patterns that are relevant to her pelvis and her meaningful issues is what's going to get her going through Italy and doing well. Our imagination are just really our only limit here.
Yeah.
It
Exactly.
really is. It's just for her, I needed her to know that she does not, to validate why the exercises in the past made her worse, and for her to avoid doing those just in the near future. I don't like people to tell people to stop doing things, but I'm trying to balance things. So I need to increase more anterior chain work and take the, so the brain starts focusing more on, oh, I have a front side of the body that needs to work, versus the back of the body. So that's why I'm focusing more on volume and load in those particular exercises. Squats, the lunges, the bows and arrows, the squats with the arm lifts. It could be a squat with a PNF pattern. Anything, you can make it up.
Yep.
As far as I'm concerned. And so that's, for us, I think as therapists, we really need to push the patients a little bit more than what we are doing them, obviously safely. But people sometimes say, oh, I feel pretty good, but all they're doing is squats. I do believe, especially if they're active or not even active, I mean, just as if they're moving around, you need to progress them through the program, even when they're pain-free. Let's say week 4, they're good to go, but you haven't progressed them. I'm making them come back to progress them because I don't want them coming back 3 weeks if they do something and they've thrown their back out again. So I don't think that we should discharge patients the minute they're pain-free. I disagree with that.
Yeah.
That's my thing. If you've done the appropriate exercise, and that's fine, but we can't leave out the activities of daily living with arms and legs. We just can't. That's my soapbox.
I think it's a good one.
Yeah, I mean, that's pretty much it. I mean, I could have done star lunges and things like that, and going upstairs with weights in her hands, to take the weights in your hand, go up the stairs.
Yep, all the things that she has at home to do.
Absolutely.
And you were speaking of the different kinds of lunges and all the different directions, and that the clock is always a favorite for people at home because all they need is a space. And there's some great apps out there. One of them is called Clock Yourself.
Ooh, I didn't know that.
Meg Lowry's work from Australia, and I'm in love with this app because there's so much variability you can use with it.
Clock Yourself.
Clock Yourself. Yep. And I make no money off of this app, so just full disclosure. Another PT actually turned me onto it, and I've had so much fun.
Oh, cool.
With some of my patients with this, and it's something that they can just turn on and do, and it's all about reactive.
Yep.
Which is the big key in the research for balance is balance is reactive. So you can't call the clock out to yourself because you're already anticipating. So you can't say 2 o'clock and go to 2. I mean, you can, but you're not going to work the reactive system.
Right.
For balance, you're going to work the anticipatory system because you know where you're going.
Yeah.
Right. But balance is all about somebody shoving you and not knowing where you're going. So this is cool because the app calls out where you're going to go and what you're going to do, and you have to react to it. And it can be quicker or slower, and you can adjust the time, and it does all kinds of cool things. You can do it in another language. You can put a calendar on the floor instead of a clock. You can do.
Oh, I love
it. Oh, it's like playing Twister, but with just a clock, really. Yeah.
Oh,
because Twister is reactive.
Yes.
Left hand, red dot.
Oh, I love Twister.
So
that's awesome.
So if they've got a Twister mat, if they've got kids, so it's a good thing to do.
That's
too.
A great idea.
This is all fun stuff.
Very cool.
Lots of fun stuff.
The only other thing I just wanted to mention before we sign off is that she did have an exercise or a position that when she did feel a little wonky in her back, that would make her feel better. And we decided that it would be child's pose because that's the one thing that made her feel better.
Sure.
And if she were to, so I basically told her after these exercises, so it's not like I said, do all these exercises and then do your one-legged standing. I'm going to progress her, but the whole theory is, do a few of these, stand on one leg. If you're good, you're good. You're good. If either the volume or one of the exercises makes you not stand on one leg as well as normal, then do your child's pose. And that will help reset everything. So I would probably have her do, if I was introducing a new exercise, I would probably have her stand on one leg and see how that feels after the new exercise. If she's good, she's good, she moves on. If she's not, then she can do her child's pose. And then I would have her progress accordingly like that. So, and I think that's important because that's the way these people get better, and they don't come back. And if they do come back, they're hopefully coming back for a different problem, you know. So it really gives them a set plan, which is what I wanted, because I think we haphazardly give these things and we don't know the rationale or the clinical reasoning behind why we're giving them. And I hope that this has helped people understand why. So that's it for me. I mean, I've seen her a couple times, so I'm going to be progressing her as I've mentioned. So we'll see. We'll see how that goes.
Okay.
Awesome. Thanks,
this
everybody.
Is fantastic. Thanks for listening, everybody. Give us your remarks. Let us know what you think about exercise progression. We'd love to hear from each of you, and keep on downloading. We appreciate it.
Yeah, thanks, guys. Bye.